Welcome to SLP Nerdcast, your favorite professional resource for evidence-based practice in speech-language pathology. I'm Kate Grandbois.
And I'm Amy Wonka. We are both speech-language pathologists working in the field and co-founders of SLP Nerdcast.
Each episode of this podcast is a course offered for ASHA CEUs. Our podcast audio courses are here to help you level up your knowledge and earn those professional development hours that you need. This course, plus the corresponding short post-test, is equal to 1 certificate of attendance. To earn CEUs today and take the post-test after this session, follow the link provided in the show notes or head to slpnerdcast.com.
Before we get started, one quick disclaimer. Our courses are not meant to replace clinical advice. We do not endorse products, procedures, or other services mentioned by our guests unless otherwise specified.
We hope you enjoy the course.
Are you an SLP or related professional? The SLP Nerdcast Unlimited subscription gives members access to over 100 courses offered for ASHA CEUs and certificates of attendance. With SLP Nerdcast membership, you can earn unlimited CEUs all year at any time. SLP Nerdcast courses are unique, evidence-based, with a focus on information that is useful. When you join SLP Nerdcast as a member, you'll have access to the best online platform for continuing education in speech and language pathology. Join as a member today and save 10% using code NERDCASTER10. A link for membership is in the show notes.
Hello, everyone. Welcome to SLP Nerdcast. We are here today with 3 special guests. This is a topic that Amy and I have not really worked with a lot personally, but we have talked about it a little bit on the podcast before. Today is going to be a deeper dive and a little bit of a different spin. We are very excited to welcome Laura Wilson, Rachel Hildebrand, and Jennifer Stewart. Welcome, Laura, Rachel, and Jennifer.
Hi, thanks for having us.
Hi.
We're so glad that you're here. We would love to learn a little bit about you before we get into all of the good stuff. Do you want to tell our audience a little bit about each of you?
Sure. Rachel, you want to go first?
Sure, I'll go first. My name is Rachel Hildebrand. I am an athletic trainer for many years, more than I'd like to state. And I don't know, Laura, like 10 years we've kind of been in the concussion space together. I always joke with her that like right before we got into it, I was at a national convention and I was like, if I never talk about concussions again, that'll be too soon. And then I always tell our students that we work with, like, hey, like never say things like that because you never know where you're going to end up. But we've been working in this space for about 10 years together, interdisciplinary. And then about 5 years ago, brought Jennifer on. And so the 3 of us have been really diving into concussions and how to manage them interdisciplinary. So it's me.
Laura Wilson. I'm a speech language pathologist, and I started my career focused more on severe traumatic brain injury, but over time have evolved into this concussion, mild traumatic brain injury space. And I would say really having this opportunity to work in an interdisciplinary manner with my colleagues who are here today has been probably one of the most fun and rewarding parts of working in this space. So we're really glad to be able to kind of share that today. So yeah, I've been working in concussion for about 10 years now.
And I'm Jennifer Stewart. I'm a clinical psychologist, and I kind of had an interesting way to come into this. My role within our university is I run our training clinic for our clinical psychology students, and we happen to have a graduate student who was really interested in sports psychology and concussions, and he was the one that was initially like introduced to Laura and Rachel to kind of help give the concussion center up and running. And I just kind of came along with him as being the licensed person along for the ride. And so I had done some work over the years with training in neuropsychology settings and other kinds of interdisciplinary teams, some chronic pain interdisciplinary work, and it happened to be a really great fit. And similar to what Laura was saying, it's been some of the most fun clinical and interdisciplinary work that I've ever done. So been really excited these last couple of years to get this center off the ground and to be doing some really cool things in our community.
I'm so excited to learn more about this. I feel like this is we've talked about this on the podcast before, just the power of interdisciplinary, multidisciplinary work, how the people that we serve are impacted in so many ways, just beyond communication disorders. And I am very much looking forward to seeing how this conversation unfolds and how we can, as professionals, more deeply embrace the idea of interdisciplinary care for this population. I think this is going to be really exciting. I do need to read our learning objectives before we get started. So participants who take this course will be able to self-report knowledge gains related to the importance of the SLP role in concussion management. They will also be able to report knowledge gains related to best practices for interdisciplinary management of clients with acute and persistent post-concussive symptoms, as well as report knowledge gains related to the process for development of a concussion center. Any and all financial and non-financial disclosures for all of the presenters on today's episode are listed in the show notes, as well as on our marketing materials and the course webpage. You can get to the course webpage to read all of this information and take the post-test for ASHA CEUs through the show notes, as well as, YouTube description and on our website. Okay, that's the boring stuff. It's already done. That's so great. I would love to hear a little bit about where do we begin with concussion management? Where would you all like to start this discussion?
Yeah, I think if Jennifer and Rachel don't mind, I'd like to start by thinking about the SLP kind of role and how that plays in and how I've thought about how that role has evolved based on what I've learned from them, and then pass it to them from there. I would say that although it's been quite a while now that speech pathologists are in this space, it's still, for many of us, a space that we're not super comfortable in, perhaps, as a field. And there have been some studies really in recent years from some of the heavy hitters in the concussion speech path world that show that really primary care physicians, other medical providers are still not very good about recognizing the role of speech path and referring to speech pathologists as necessary. So I think that one of my goals when I've had the opportunity to go and talk in more of Rachel's spaces and in the athletic training world is to really just kind of highlight the potential benefits of including speech pathologists in the management. So when I think about that, I think about our training in terms of cognitive communication, right? So we have training that helps support things like attention and executive function skills that can be impacted by concussion. But we also have a lot of training related to things just like accommodations in the schools, right? So we're really good at thinking about like, hey, functionally, what are the challenges and how can we adapt the environment to help people be successful? And that's a really important thing, both acutely post-concussion and in the folks who take a little bit longer to recover as well. So I think, again, that sort of accommodation space and then the more traditional cognitive communication rehab space is really important. And then I think another role that we have is around education. And that's not unique to speech language pathologists. All of us have that role. But there's been a lot of work to show that the way in which we talk to folks about concussion when they present to us early on, impacts how long it takes them to recover. So the words we choose, the way we talk about it, the way we frame our expectations, the way we understand their goals, regardless of what else happens in therapy, can dictate to some degree how well their recovery is going to go. So I think that education role is really important.
I'll just add to that, specifically in the role of the speech pathologist. Laura and I do a lot of dual task therapy together. So and we kind of base it on who takes the lead based on whatever goal our particular patient needs to work on. But I might have them do a physical activity and Laura's just throwing cognitive strain at them. So I've learned a lot from her. Now I'm like, hey, I can do that. I can't. Not near as good as she can, or other speech pathologists in the clinic. But I think that that's a big way that the interdisciplinary aspect of the concussion clinic or concussion management comes together as well, is really playing off of each other's strengths and trying to dual treat as much as possible for the individual patient.
I think too, in the same way we would do in a more sort of like traditional rehab setting where PT may be working on transfers, for example, but a speech language pathologist may be working on sort of like sequencing and environmental accommodations to support them being able to engage in that transfer. I think we have a lot of conversations as a team, and I think that's an important role of the speech path as well, to say like, hey, we're having trouble because they're not doing these homework exercises at home. And so we can say, okay, well, like, is it a memory concern? Do they not understand it? Is it a sequencing? Like, what is the challenge there? What is the barrier? And those barriers could be cognitive communication in nature. They could be psychological in nature. You know, there are many reasons. So kind of troubleshooting can be an important role as well.
As we're talking about this, I'm trying to conceptualize what your clinic looks like and who is coming there. So, before we started recording, we were talking about how, when I was in grad school, I did like a placement at a subacute rehab. I'm assuming those aren't your clients. Who are you seeing? Are you seeing mostly like adolescents? Are you seeing sports related? Kind of who's your population there? If you could help us just better understand that a little.
It's not what we thought it was going to be. I would say I think we anticipated a lot of sports related concussions. That is, in large part due to Rachel's connections in the community that she's built over many, many years. We are well connected in the sports related concussion community. But I think what we've come to find is that a lot of the sports related concussions that occur among people who are embedded in a system that already has support for them. And so as long as they're having kind of a typical recovery, they are getting services to some degree and may not need an interdisciplinary clinic that specializes in concussion like ours. Now, we do see those folks with sports-related concussion who may have slightly more complicated recoveries and who may not be kind of responding to standard of care. But we have seen a lot of individuals with post-motor vehicle accidents. And what we've kind of come to learn is a lot of these folks are not embedded in communities or systems that offer support. And so they're not getting the care that they need either like right away. And so often that can prolong recovery. Or they're coming to us pretty quickly because they, need to get back to work and have this concussion and are trying to figure out what's going on. So some falls, if we think about the main causes of concussion. So, and we use concussion interchangeably with mild traumatic brain injury, right? So common causes would be falls, motor vehicle accidents, sports-related concussions, interpersonal violence, another cause. And we see patients who have concussions as a result of that as well. But much heavier on the motor vehicle accidents than I think we anticipated going into things.
That's really interesting. I mean, that makes sense, right? Because we are a nation of cars and there are so many people driving around and we have a lot of motor vehicle accidents. So yeah, that does make sense, but that's interesting. That wasn't what I was picturing. So I'm glad I asked that question. With your varied clientele, does that mean that you're finding yourselves interfacing with different agencies, right? Like, are you working with people who are still attending schools, or are you coordinating with their primary care or other agencies out there? And what does that look like?
Yeah, so we do a lot of release of information for that reason. So we're coordinating with primary care a lot. And Jennifer can speak more to this, but we might discover that through their injury, they have, more intense like mental health dealings that they need to help with. So, coordinating with long-term care that way. I mean, we're set up to be pretty short-term care. And so primary care, we do a lot with neuropsychologists. So we're referring out to neuropsych, working with, if they are younger athletes, working with an athletic trainer or coordinating with parents, trying to coordinate with the schools, and stuff like that. So yeah, we do a lot of coordinating care through our center as well.
I think maybe it'd be helpful to, if it's all right, to kind of talk about how our clinic is structured and what that looks like to kind of set that framework. So, like Rachel said, we're set up to be short-term care. So we will see anyone who has had a concussion. We don't see people same day, but as long as it's at least the next day post their injury. And they don't have to have a diagnosis of a concussion, of an acute concussion. That falls within the scope of practice for Rachel. And then we see people up to, we typically cap at about 2 years post-concussion, and we can get into more about why that is if that's helpful. But so we see a pretty big variety of time post-injury. And then for our individuals who are more acute, our kind of expectation is that we would kind of plan for about 4 weeks. And some people don't need that long, right? Some people are kind of back into their baseline, back at their, normal desired life activities sooner than that. But we plan for about 4 weeks. For people who are further out post-concussion, so suggesting that they have perhaps some risk factors that have predisposed them to taking a longer time to recover, then we'll expect to see people for about 8-ish weeks. And then we reevaluate. And if people need to be seen longer and are still kind of a good fit for the center, then we can continue to see them as well. But we're not really set up to see people for, years at a time. And for most people with concussion, that's not an appropriate care plan anyway. So for the most part, we're getting people in, getting them the services that they need, and then, hopefully getting people back to where they want to be kind of functionally and quality of life wise. And if not, then we often are going to kind of refer out to other community resources.
I want to comment on something that struck me about what you said a few minutes ago related to people who are dealing with a mild traumatic brain injury, concussion, regardless of how far out they are from the incident of injury, that they tend to lack a community. Something about that really kind of stood out to me. And then, Rachel, you mentioned that there may also be some mental health components. And I can't help but feel like people who have experienced this trauma, this head trauma of whatever source, motor vehicle accident, sporting event, you also mentioned interpersonal violence. I have to imagine that there are components of community, there are components of interconnectedness that come along with that interdisciplinary care that are critical for healing in this population or for recovery. Can you tell us a little bit about that aspect of community and community support and how your interdisciplinary team works to strengthen that community?
I think one of the biggest things is access to care. One thing we've learned is that, what people are getting told if they present to like their primary care or to an ER is they're getting told a number of different things in terms of what they should and shouldn't be doing immediately post-concussion, and what they should expect in terms of trajectory of their recovery. And so when we see someone who's been, 6, 9, 12 months post-injury, even out to 2 years, and they're still struggling with many of those things. They see their injury as the precipitant of all these things that have been going on for them, and they're presenting to their usual care team with no real results. Like it hasn't followed that trajectory. The doctor is telling them, well, there's nothing that I can do. You should have recovered by now. It leaves them in a really frustrated place. It leaves them in a place where they don't feel believed, or where they don't feel heard. And so being able to at least give them a different perspective of like our intakes are interdisciplinary when a new patient comes into the center. So we've got all 3 disciplines typically represented at each of the intakes. And so we're all 3 listening to different pieces of that and trying to understand like what role each of our disciplines could take in that care that would follow. And so being able to just offer options, offer things that might be, take a different approach than what they've received before. And so oftentimes that's one of the biggest things for our clients who have a more prolonged presentation is just that feeling of being heard, right? Like if they've just gone to their typical care and they're not feeling like they're heard, now they're getting, a space where they have three different disciplines and who they probably haven't worked with before. And they're listening to their concerns in a very different way and able to come up with a plan to hopefully make some movement there. And so I think giving that hope is a big piece of it. Obviously, like some things might, we might need to work on from the acceptance angle of like maybe there are some things that aren't going to quite go back to the way they were. Maybe that's injury related, maybe that's normal aging related. But it's something that we can at least give them a different perspective to work from.
You mentioned, oh, sorry, go ahead, Rachel.
No, I was just going to say, I was just going to follow up. I do think one of the coolest things about our clinic is so many times we will have people come that have gone to primary cares or, gone to various healthcare providers. And it's not saying anything about healthcare providers. We're just specifically trained in concussion and concussion management. And we're able to be like, yes, what you're experiencing is real. Like we've seen it, we deal with it every day. And just kind of you can almost see the sigh of relief come off of our patients as they're like, okay, like somebody hears me and understands. And I think that just that goes a long way to healing, of saying like, yes, like this is a real thing. And through our ability to approach it in three different directions, I like a lot of it is just like being said, like, yes, we validate you, like we hear you and what you're experiencing is real. So, I think that that's a big aspect toward the recovery in this way.
I think something that's challenging is that the best practices for concussion care have changed pretty dramatically in the last 20 years. So I can reflect back to a sports-related concussion that I sustained, in high school. And at the time, everyone got a CT scan of some kind if they had access to it, right? If you went to the ER, that was like common practice. They told you that you needed to be checked on every 30 minutes. So you were, they have someone wake you up constantly to make sure you were doing all right. Essentially, you were told that you needed to like rest in a dark room until your symptoms had gone away. And all of these things that we know are actually not best practice. So there are specific guidelines now for example, who should get a CT scan if they present post concussion. And frankly, it's not necessary or helpful for most people. Two, we don't wake people up all the time anymore. Rest is really important. And three, there's pretty clear evidence now that prolonged rest periods actually make recovery harder, and that we should do the management that is really based around, and I think Rachel's done a really good job of reinforcing this in our clinic, this idea of symptom exposure and then recovery, right? So you engage in activities, you don't want a major symptom spike, but your symptoms will elevate a little bit when you engage in physical and cognitive work post-concussion. As long as they just elevate a little bit, then you do that work and then you step back and you recover and then you do it again. And, this sort of active recovery process is really important. And so when I think about when we see clients now who perhaps are my age and were kind of raised in a much different kind of practice environment, they, thought about it as getting their bell rung as a kid, or, maybe they were told to toughen up or whatever. And so when a concussion happens and people don't get better, so to speak, right away, they think something has gone sort of terribly wrong. Additionally, and again, not trying to knock other providers, but if you think about primary care physicians, they have to manage like everything. And so we do see some situations where people are not up to date in terms of best practice recommendations. So they come to us, a month, for example, after their concussion, and they have not like returned to school or work in any way at that point, because they're like, no, I'm waiting for my symptoms to go away. Like, okay, what are you doing with your day? I'm just hanging out at home waiting to feel better. Like, oh, okay. So we unfortunately see that like those folks are going to take longer to recover. So we're navigating some like changes that have happened more recently in best practices, some like stigma and misperceptions on the part of the patients. And so, yeah, I think that sort of hearing, listening, validating, educating piece goes a long way. We've had folks who were essentially told, like, you will be back at baseline in 2 weeks. I'm like, just straight up, you'll be fine. And so then if your doctor tells you that and then you're not fine in 2 weeks, you feel like something is wrong. And we've had actually more than one occasion in which someone was very concerned that they had dementia. Because they're like, it's been 3 weeks. They said it would be 2 weeks. I have this family history, like like, what is the rest of my life going to look like? Well, let's slow down a little bit and kind of talk through that. So it's yeah, a lot of education, and that's Rachel heads up our community outreach, and that's part of our mission too, is to try to get the word out directly to just general people in the population, but also to providers, to make sure that we can all get on the same page about how to manage this and what that message should be.
I want to quickly just reflect some of this back to you and connect it to your first point about the role of the SLP. So everything from making sure that a person feels heard, and the power of feeling heard, feeling validated, especially when you're maybe getting misinformation or you've been wrongly diagnosed, or you have the comment had my bell rung, evoked some sort of like 1930s guy on a railroad, like you have all of these cultural misconceptions or bad information in the community, and the power of feeling heard and the power of being validated. Thinking about the SLPs who are listening to this, who, we don't necessarily get direct care and counseling as speech pathologists. A lot of us do have teams, but maybe the relationships that we have with the school counselor or the relationships we have with the other mental health professionals in our field could be strengthened or better utilized or better brought in, just because of the power of that that phenomenon of being heard and being validated in the face of the misconceptions and the bad information. Do you all feel like I mean, I guess this is kind of a rhetorical question, because of course you do, but do you agree that speech pathologists should be, making better relationships with their psychologists, their school counselors, or being, more open to embracing components of counseling, taking courses in counseling? It's just, we talk about this on the podcast all the time. It is such an important piece of every single thing that we do in speech pathology, and yet it is often not the central focus of our jobs. I don't know. Commentary, question. Please give me feedback. Maybe
I'm gonna
perhaps
take
I've
that one
babbled
off,
for too
Laura.
long.
No, I totally agree with you, but I think that's healthcare in general, right? I've recently consulted with some of our local high schools, and and from the athletic training standpoint of their concussion management, and I'll look at it and I'm like, good, who's your speech pathologist at your school? And they're like, we don't know. I'm like, who's your mental health provider at your school? We don't know, and I'm like, no, like those are the people you need to go talk to. So I'm gonna not throw the SLPs under the bus and say that it's on SLP to make that connection. I think it's a general um overall in healthcare, we need to be making that connection. And because we have so much to learn. It's just like the primary care physicians, and we'll tell our patients all the time, like, because they'll be like, well, why didn't my PCP tell me this? And we're like, because they have to know every other system of the body, right? Like, we get to talk about the brain, and the brain alone. And so I think it's incumbent upon healthcare as a whole to get out there, right? And kind of get out of our own bubbles and be able to figure out where we can collaborate and where we overlap. I mean, in my own profession, we were talking about standards for education the other day, and we had people like, we need to do more about like this and that. And I'm sitting there going, no, like literally, I was like, no, we need to just talk to the SLPs. What are we doing? Um, vocal cord dysfunction, that was one of them. And I was like, we don't need to know about that. We need to send it to an SLP. So I do think that there's an element that, yes, I mean, the answer to your question is yes, like SLPs need to get out there. But I think every healthcare professional needs to get out there. Now Laura can pick it up.
I think one of the things that came to mind with your question about kind of counseling and that role and that training, we also are a teaching clinic, so we supervise graduate students in the clinic, and I would say that our students go out and work in lots of settings, but I think that the Concussion Center has been a little bit nerve-wracking for a lot of them because a lot of it is counseling and a lot of it is responsive. We see, especially in more acute concussions, we see pretty quick changes. And so unlike perhaps some of our other patients where you could plan a week in advance what your session is going to look like, in these sessions, we essentially go in, we kind of reflect on the goals that we've set together as a team with the patient. And then we say, okay, so this was your goal. How has that been going the last couple of days? And sometimes they'll say like, actually, that's been totally fine, but this issue has really been a challenge. And then we have to be ready to sort of pivot and educate and problem solve in the moment while building in that those counseling skills to help build insight and help the client think about their role in their own role in their recovery and that kind of thing. So it's I think one of the things that makes it fun to me to work with this population is that it's you never quite know what's going to happen when you walk in the room. I think that is also something that makes it a little bit intimidating and a little bit of a hard entry for clinicians who are newer to this area. So.
I will throw Laura under the bus a little bit though. When we first started this clinic, she'd come up to me and she'd be like, because athletic trainers, that's just, what we do. We're always on our feet. She's like, so what are you doing? I was like, I don't know. When I see him, I'll figure it out. And even our psych students, sometimes they'll be like, what do you mean you're figuring it out in the room? I was like, I don't know. That's what we do. It has been fun to watch our students also adapt to that and figure that out and navigate that.
Yeah, I think that's been one of the most interesting things about working as part of this interdisciplinary team is like everyone's approach to how we set and measure goals. What are we doing in terms of prep? So we staff all of our patients every week. And so that's often like a funny, like comedic point, actually. It's kind of turned into like a comedy bit to where like Laura's on the side of like, but what's the goal? And Rachel's on the, I don't know, we're going to figure it out. And so it's been an interesting, and then psych is kind of in the middle of like, well, okay, we'll just kind of hold both at the same time and like see where it goes. And but yeah, Rachel mentioned the stuff with training. I think that's also been a really interesting piece because how the role that our trainees play within the center has also played an interesting role. And so, I'll start with our psychology ones. Our psychology doctoral students are in their third or fourth year of training. We've been lucky to have some people who, they're there on a placement for typically a full year, if not. Everybody stayed for 2 years, which is really exciting. They've loved the work that much. And so they are part of the team. They are an active part of the staffing. They are contributing. They're creating their care plans. I'm not in the room. I just watch things over video and have fun doing that. And so they are kind of treated as like mini providers. They are like their voice, their opinion is what's guiding that. Their observations. They're doing the intakes, all of those fun things. Whereas on Rachel's side, like she has, her students rotate with her 2 weeks and then they're on to the next placement. And so the role of the student within that is very different for each of the disciplines. And so it's been a really good opportunity to kind of see how each of our disciplines approaches clinical training and what how that looks different within this particular setting.
There are so many benefits to an interdisciplinary collaborative setup like you guys are talking about. I mean, from the actual training and content skills that people bring, but also, like you're mentioning, just the differences in training and approach and being flexible and working within that. Jennifer, earlier you mentioned just your interdisciplinary assessments, and I was wondering if you guys could talk to us a little bit about the different pieces that you're bringing to that assessment process and what that might look like. And then I guess also if there's a difference between what your assessment process looks like for somebody who you're seeing in that acute phase versus somebody who you're seeing who's maybe one of those more chronic patients.
That's been
Yeah.
something that we have been refining. Let's see, the center's been open for about 2.5 years now. And that's been one of our goals for the last 6 months or so, was to really have a more standardized practice based on sort of the stage someone is at in their recovery. And I think when we first started, it was largely Rachel and I and one of the initial clinical doctoral students, psychology doctoral students. And so we were able to be a little bit more flexible. We could staff things, like sort of chat about things a little bit easier. And then as it grew and we had more patients, and then like a big influx of student trainees who were going through and that kind of thing, we just realized that we needed to sort of like have that nailed down a little bit. So Rachel actually spent quite a bit of time finalizing those protocols. So maybe you'll talk about those, but I want to just kind of highlight that it was definitely an evolution. So I think that sometimes, I know when we were first starting out, we kind of looked to some other centers that existed, and it just frankly felt a little bit overwhelming. They had all these protocols, and it seemed to be all so clear cut. But so I just wanted to mention that like that has evolved, and I think we're pretty happy with where it's at right now. But we're tweaking it constantly, and we definitely didn't just sort of hit the ground running with those protocols. We felt it out and learned from it, and that kind of thing too. But yeah, Rachel, maybe you can talk about the current protocols for the different stages.
Yeah, so I think we're down to now just 2 protocols. We started with, as Laura said, we were just kind of all over the place. And then we went to 3 protocols with like this subacute phase. And then we've realized like acute and more prolonged, down to kind of those 2 phases. With our acute, it's so our intake, as Jennifer mentioned, we have all 3 professions in the room at the same time. And the reason we do this is, well, several reasons that we do that, but one, I mean, you're talking to people with brain injuries, so you don't want to just keep asking them the same questions over and over again. So one, it allows us to be more efficient. 2, Laura might ask a question and they answer it in a way that makes me go, oh, wait a minute, now I have a question based on your answer. So it allows us to not only ask the same questions over and over again, but allows us to kind of hear the same information from 3 different points of view, which allows us to then, whenever we do our rounds on the patient, then we're able to like, but they said this, so I heard this, and I kind of heard this, and so maybe we need to dual task here, or we need to do something here, and so that allows just like a little more efficiency, I think, for our patients. The other thing that a lot of people will come in and they'll feel fine when they start. And then with all 3 of us in there, again, from different points of view, you can almost just watch their cognitive decline happen. And so as we're talking to them, it allows us to visually see how sitting in a room, how having to cognitively think, or emotional ability, and kind of how their emotions go up and down, all play into that. So again, it allows us efficiency, better patient care, but then also to like visually see what's happening, instead of Laura's in the room first and she's like, they're great, what are they talking about? And Jennifer's students in the room last, and they're like, they were terrible, they couldn't talk to me, right? So we have everybody come in. We every day we do a symptom checklist. We do cognitive.
Can I pop in real
Yep.
quick? Because I don't know with the audience. So in speech path, like there's definitely
Oh, sorry.
so no, so symptom checklist. It's kind of the standard ones are like 22 questions, and you just rate it on a scale of like 0 is I don't have that symptom, 6 would be it's very severe, and you just get a total score. It's things like, do I feel mentally foggy, any dizziness, any headache, trouble falling asleep, and it's sort of like mood related questions. So it just kind of covers those areas that we see: sleep trouble, cognitive trouble, physical trouble, psychological trouble, essentially. It covers those kind of main points. So it's a really common way that we kind of track subjective recovery, essentially.
Yeah. And so then with that, and then we'll have an interview. So it like just basically what happened, what symptoms did you feel initially, how, depending on when they came, how long it's been since their injury, like how have those changed now, what makes them worse, what makes it better, kind of a standard intake interview. Then we'll do trail making test B and verbal fluency from the cognitive standpoint. And then as Laura mentioned, with the symptom checklist, we're able to break it out into those 4 domains. So they might be telling us, I don't have any trouble with, or all my, they might be telling us in the interview, like, I'm emotional and all these types of things, but then in their symptom checklist, like, it's all cognitive that they're reporting. So it kind of allows us to again, when we talk about a care plan, be like, well, they weren't acting like this, or they didn't tell us this is a problem, so maybe it's not like consciously a problem, but it's subconsciously a problem in some way. So, and that's kind of where we're able to look at like dual tasking, where that comes in. Then everybody comes back for a full physical assessment. We used to try to do the physical as a part of it. I think our intakes were about 2 hours long. It was
No good.
miserable it was no good. It was miserable for them. So we parsed in the physical testing out of that, which is a lot of balance testing, looking at orthostatic changes and Buffalo concussion treadmill tests and stuff like that. Then we, if we've just had our weekly meeting, then we might round on them earlier, but then in our weekly meeting, we'll talk about what we found, what our care plan is from each of the 3 disciplines. There might be times where we're like, from like an athletic training standpoint of there's no dizziness, they're walking at least 20 minutes a day. It doesn't increase their symptoms. Like they don't need to see us, they're good. Or, psych, they might have a lot of emotional ability. So, or a lot of, trauma related to how their concussion happened. And so, psych might be like, I need to see them for an hour for at least 3 weeks. And we're like, okay. Or moving from there. And then our prolonged
Can I pop in real quick though?
Yep,
So I want to make
absolutely.
sure to mention. So for
Yeah.
our acute as well and our prolonged, we also do the PHQ-9. Which is a depression screener and also helps with our risk assessment. So Jennifer did a lot of work in kind of thinking through how we were going to kind of check in on that, because that can be a concern post-concussion, and frankly, in anytime in healthcare when we see patients. Jen, will you talk about our kind of assessment
The
practices and
emergency
our
I was
like
gonna say.
our risk assessment and that kind of thing?
Yeah, you read my mind, Laura, because I was going to jump in with that too. So yeah, like Laura was mentioning, like certainly after a significant injury, like anytime like you have a big life upset, but certainly after like an injury like a concussion, the risk factor for suicidal thoughts increase. And so, and then if you have, a physician or someone who's told you like you're going to be better in 2 weeks, and suddenly it's 2 weeks and I'm still feeling really awful, then that can increase some of that hopelessness as well. So we've seen it really in our older adults, in our children and adolescents even. So we've had to get creative with some of our measures to make sure that we're assessing depression and risk-related symptoms across the board. But when we were getting ready to open the center, we did a lot of work to kind of create a decision tree for what would happen if like someone screens positive for on that PHQ-9, if they say that they're having thoughts of harming themselves. Who follows up on that? When do we need to kind of like sound the alarms of getting someone to do a full risk assessment with them more quickly? And so if other providers are looking for some resources, a good one, in addition to the one question on the PHQ-9, if you're familiar with that one, is the Columbia. So the Columbia Suicide Severity Risk Scale is I'm probably butchering that name. I might need to go back and look for that. Is a really well validated brief measure that really any discipline can do. It's been rolled out. There's some good like YouTube trainings and things like that with on how to other disciplines can use that in a number of different settings. If you're encountering someone who's got some emotional lability, they're reporting, some thoughts of harming themselves, and you're like, "Ooh, I need some more information, but I don't quite know how to start getting that." That can be a really helpful tool.
I want to jump in for a moment because back to sort of SLP training related to counseling and that kind of thing. I know people can feel a little bit nervous sometimes, but giving a measure like the PHQ-9, which is the Patient Health Questionnaire 9, it's 9 questions, and it's really just these questions. They circle on a Likert scale. The patient does about how often certain things are bothering them. It is absolutely within the scope of practice to give a screening measure like that for an SLP. And if you're going to work with this population, it's really important to get comfortable. I really like that one in particular because it has been validated on individuals with brain injury. As you can imagine, there's some like symptom overlap between depression that is not caused by injury, for example, and brain injury symptoms like sleep, for example. It can be disrupted because of concussion and disruptive because of depression as well. So this one is nice because it has been like validated in the brain injury population specifically. So absolutely within scope of practice. And if you're going to use a tool like that, there needs to be a plan in place. So it is appropriate to give, but it is not appropriate to give without a plan and decision tree in place, because you can say like, oh, okay, well, they are having or they like are showing up as like potentially severely depressed, or they're having these suicidal thoughts, that kind of thing. You have to have a plan in place, and it's really not in my view, that shouldn't be a plan that's generated by a speech path, right? That should be done in consultation with our experts in that field. So I would encourage folks to get familiar with tools like that and to think about who their resources are to help them think through that like action plan for after they use a screening measure like that.
So that brings me to a question. I'm also thinking about our last learning objective related to developing a concussion center. When you talk about, perfectly fine to provide this screener, but you need a decision tree, you need a protocol, that to me speaks to procedures, business infrastructure, team cohesion, collaboration related to specific policies and procedure. And now it kind of feels like we're starting to talk about how you develop some of these things. I'm thinking about the SLPs who are listening, who are inspired by interdisciplinary care when treating individuals who have concussions or mild TBIs. What are some of the components that go into, like, what are some of the first steps? How do you initiate building some of these things? As you all know, speech pathologists, we are in schools, we're in hospitals, we're in private practice. People with TBIs are in all of those places. So I have to imagine that putting some thought to some of these policies, procedures, infrastructure, not necessarily developing a quote center in and of itself, but I'd love to hear your thoughts around starting to develop some of this stuff to put it into place.
I think it's going to be pretty setting dependent, like you mentioned. So maybe let's start with school SLPs first. And a lot of this is going to be governed in part, when you think about policies and procedures, by state law. All states have some sort of concussion law on the books. Most states have concussion law that mentions at least return to learn. Not all of them, but many states do have some regulations around return to learn. And so these regulations are going to be heavily related to student athletes. But essentially, many of these return to learn laws will say something like, they're similar to return to sport, right? So you perhaps can't go back to the field or the court or whatever until you've got a release from a medical provider. But the return to learn will say something like there has to be a mechanism in place to support the person going back into the classroom. Now, how well this is implemented, how many supports are actually provided, that's, that's a little bit tricky. But that's one place. So if you are in the school and you're like, okay, I want to get a little bit more involved in this area, I would recommend looking up the state law around concussion just to see what the expectations are. And then I think, like Rachel mentioned, thinking about the stakeholders in the school who might be interested in having this discussion about concussion. So some folks that come to mind, and it's not an exhaustive list, but it'd be speech path, it'd be athletic trainer, it'd be the school nurse, it'd be the school counselor, it'd be the special education director, and it would be an administrator as well. And then I always think anytime you're doing something in the schools that it's that you would like to have classroom teacher representation, just because they are the folks that like know what's going on, and they're the folks that spend the most time with the students. And I don't think I said coaches, but I think having coaches involved in that discussion can be really helpful. Now, I know there's
I
some,
would
like,
even add to
please.
that list PTA moms, like the PTA president. We've learned through athletic training, if you want to get something moving, get the PTA moms involved. Um, so I mean, as just if you're kind of like, if you're sitting writing a list, like include the PTA president, because they're going to be able to move the school in a way that maybe people internal to the school aren't going to be able to do that. They're advocating for their kid, right? Like, so everybody wants to help the kids. So
So thinking through those stakeholders, and then thinking through state laws and then any district policies and that kind of thing. And then a lot of it in the school is going to be about, like, I think some big questions to ask in those conversations are like, one, how do we find out that a kid has a concussion? It's, easy-ish if you have good athletic training coverage and that kind of thing. It's easy-ish to know that a kid had a concussion at the school basketball game this weekend or Thursday night or whatever. But is there a policy in place for how the athletic trainer like disperses that information to the rest of the school? Is there a point person that finds out and then they disperse it, or is it more of like a team approach? And there are different models for that. Some school-based concussion teams will have like a point person who disperses. Some schools will have like several potential point people, and it like rotates on a case-by-case basis to sort of like spread the workload a little bit. And then some people will sort of do it based on like primary symptom presentation. So like, this kid had a concussion. They seem to be having the most difficulty with fill in the blank. And so like that, so if it's more of like the cognitive stuff, then perhaps the speech path would take the role, or if it's more of the physical stuff, athletic training or school nursing may take the role, the lead role there. So there are a lot of models for that, but thinking about like, how do we find out and how are we dispersing information? Two, how are we kind of tracking their recovery, right? In those acute days, we really need to be,
can I jump in there real fast?
Yeah, absolutely.
She mentioned just like it's easy-ish to know, and we say ish because we're still relying on students to report for the most part, but it's easy to know on those situations. But just to emphasize the importance of having the teacher involved, you might have a kid who's not involved in school athletics, it's club athletics, or it is that motor vehicle accident, and it's going to be the teacher who first recognizes this is not the same kid that was in my class yesterday or last week. And so it's going to be the teacher. And so especially if you're an SLP in the schools, doing a lot of that outreach to the schools or to the teachers of, hey, like, if you need a point person, let me be your point person. I know they're busy. I know they're overloaded, just like everybody else. So I know that's a much easier thing for me to say than school-based SLPs listening to this right now going, yeah, right, I'm not adding another thing to my list. But, or having that group that maybe it is maybe the administrator, but really educating the teachers of here's who you go to. And then a point that Laura makes quite regularly that I just want to make on her behalf, and please elaborate on this. Even when we're trying to educate our own professors at TU, when students have concussions, a lot that she'll talk about is, will you have this assignment? They might be having a hard time doing this assignment. What's your learning objective? Especially with students that might be experiencing prolonged recovery. that they're only in the classroom for half a day, really working with teachers on what's your learning objective and how can you meet that same learning objective, but in a different way. So, and I'm totally stealing your thunder, so jump in and cut me off at
Do
any
it. I
point,
love
Laura.
it.
But if the assignment is to write a paper, but they're having a hard time looking at a screen because of bright lights and that cognitive load, can they orally, with the teacher one-on-one during a tutorial session, like basically give the paper to meet that learning objective. So those are kind of the things where I think Laura's done a great job of educating our community as well as even our own professors on campus of how to meet still those same cognitive goals. Because as we see, and I'm gonna like jump into, I'm totally out of my realm right here, like this is Jennifer's realm at this point, but what we have seen a lot, especially in school aged kids, is that the further they get behind in school, the more you see that anxiety go up. Might even see that depression go up, and then you see their concussion symptoms get worse, and it continues to prolong. So the more we can not get into that cycle, the easier it is for them to recover. Okay, now that I've totally stepped out of
Nailed it.
my lane, you guys take over.
Absolutely nailed it, Rachel.
I think one of the things that comes to mind, and we're starting with like the school setting, but I found it helpful for teachers, for coaches, for patients themselves, for parents, just for people who, those patients who like want to get back to work, is if we have that message like, hey, I know it's hard, but if we take care of this correctly, and that's probably not the language I would use with it, but if we like manage this well early on, the probability that you get back to baseline faster is there. Whereas if you're like, I know, but this, but I got that, but what about this? And you push through, those folks are at risk for a prolonged recovery in general. So I know we have some students who get pushback from teachers who, they're like, they said I have a test, or they said I have to do the whole sheet. And I think that message of like, if we tackle it now, this is a short-term problem for most people. And that can go a long way with helping people like recognize that like, okay, I just need these brief accommodations. And so I think that's another thing with thinking about the school setting. So when you're thinking about how to like launch this, this is a short-term thing. So this is not like taking someone onto your caseload indefinitely. This is saying like, hey, we are going to need to do, ideally daily check-ins of symptoms so that we can adjust accommodations. And as long as we're staying on top of that, this is something that for the vast majority of people will get back to normal, and people will be able to like get back to their, their kind of regular lives as they were before their concussion. So I think, policies, procedures wise, school based, check your obviously district policies, check your state law, and then start thinking about who those stakeholders are, and then essentially get a plan in place. The REAP program, so that's REAP, started in Colorado, but now has been adopted by a ton of states, has a really good kind of model for what management can look like in the schools, and they've got a lot of resources. So if you're like, oh, I don't even know where to start, if you look for that, that's a really good kind of guide and things to think about, and again, who the stakeholders may be and that kind of thing. So that's a good resource. If we step out of this, oh, sorry, go ahead.
I was just going to build on what you were saying with like
please.
Going back to the active recovery piece, because I think really what you're aiming for, especially with that acute phase, is like needing to hit kind of like a Goldilocks zone, right? Because like too much prolonged care could lead to like prolonged presentation, but also like rushing things too soon, right? Like trying to like just kind of pushing through and like I'm just gonna jump back in and like hope for the best, right? And rushing those things too much can also lead to prolonged symptom presentations. And so trying to really find that spot where it's like your symptoms are going up a bit and then allow it to recover back down. And like Laura was saying, like that short-term accommodation, right? Like this isn't something we were expecting for longer term. So, and then the psych role within that is typically like, how do we have those conversations? So I think it can sometimes be a little bit easier on the side for like if it's with a school, if it's in a setting where there's more likely to be a number of stakeholders, or at least a person who can advocate for the students. It's a bit harder if it's an adult and they're needing to have a tough conversation with their employer about like how do I accommodate my day so that I can help get these things back? How do I go back, maybe for a couple of hours and start to like titrate that up? That becomes a much more challenging thing. So how do you have those difficult conversations and like deal with the emotions around those, right? If I'm going to go into my boss and say, I this is what I'm struggling with, this is what I need. It's understandable for that to come with some pretty strong emotions, especially as I'm also trying to manage the stress of like navigating the rest of my life again, and the normative fear and anxiety that comes with like, oh, okay, I'm still struggling with this. How do I then try to work towards getting back to my normal? So
When we think about more either community kind of outpatient settings or medical settings, it's a different set of challenges, and I think that's largely due to funding, right? So then it becomes a challenge of like, who is the referral source? What does insurance cover? That kind of thing. So I think that's probably outside of the scope of the conversation right now, just because it's so complicated depending on your setting. So I think if I were a speech path in one of those roles, and I was interested in getting involved in this in working with this population a little bit more, I think the first thing I would do is make sure that I like felt kind of clinically competent. We can talk about some resources for that perhaps. But then I think it's just making those connections. So getting to know the sports medicine physicians in your community, getting to know the PTs and OTs in your community, starting to kind of like outline what that role could be. And there's some really interesting. So, when we talked about the role of the SLP earlier, that was a little bit kind of in generic terms, but there's some really interesting roles that speech pathologists have played. I think about it's at Miami University, where they've had a interdisciplinary concussion center there for over 25 years, and speech language pathologists are involved in baseline testing of athletes, for example. I think about, we met some colleagues from Baylor who are in the process of working on developing a motor speech based assessment to help with diagnosis of concussion. We have talked to folks who work with the VA who do more like group-based dual task kind of interventions for the veteran population. So there are lots of avenues there. So I think that it's kind of thinking about what the community need is and who those stakeholders are to figure out like what your kind of like what area you would like to focus and build into. But again, just, we don't want to pretend like the financial component is not an important part of it. We're very fortunate, so I think it's important to be transparent about that. We have grant funding that allows us to do this, and our center right now, our services are free of charge to the clients themselves. So we have a lot of flexibility that not everyone has, for sure. So again, if you're like more out in a community setting, I think first steps are making those connections. Once you kind of feel competent in this area, and that doesn't mean you have to be an expert, right? Like, we all have to start somewhere, no problem, but like making those connections and kind of thinking about what the community need is there as well.
And I think I want to piggyback on something that Laura had stated with, we were talking about policy or procedure development, being flexible, right? And realizing that like you're not going to get it right the first time. I think I don't know what iteration we're on terms of like all of the different things, but I just understanding that like starting, right? And then realizing like as you're making those connections and learning. Laura and I started at TU at the same time, and literally what I knew about speech path was Arctic, right? Like I was like, oh yeah, like you help little kids say ours. That's what you do, right? And she was like, you give water. So that's where we started with each other. I think when Jennifer was psych, we were like, you talk to people, we don't know. Right. And so ourselves, we can talk a little more eloquently about each other's services at this point. But Laura and I have been working together closely for 10 years. My first ASHA that I went to, I was like, you guys do that? You guys do this? Now ASHA literally is the highlight of my year. I love going to ASHA. because I just learned so much that also applies to my job because there is overlap. So I would just encourage people that are maybe thinking in this space, even if it's not concussion, but just interdisciplinary management in general, like just start, right? And just go to a different conference and learn what they do and start making those connections. So that would be my like, I don't know, thoughts on how to get started for our third learning objective, is just start. Kind of set out and know that you're not going to have it figured out correctly from day one.
I think another thing that we've pushed into is we've formalized our kind of orientation a little bit more, both for our patients in terms of like kind of a manual that we give them, but also for like our student providers and new providers to the clinic as well. Just because we found that from both sides, our trainees and our patients, expectations are a little bit all over the place. And so we found that kind of doing some very upfront discussions about that has been really helpful. So from our patient perspective, we have been using goal attainment scaling a little bit more, and we do that as appropriate across the professions. So essentially, we're working with the patients from the get-go after their intake to help them identify goals, like functional goals, and then thinking about like within the time period that we're going to be offering care, what sort of success would look like and what the metrics of success would be like for them. So that's been really helpful because it kind of forces us to have that conversation about the timeline and about what is reasonable to expect for recovery within that timeline. So that's been a helpful tool for us there. On the provider side, we've tried particularly related to that counseling piece. We've talked a lot about like metatherapy, right? So there's a really good article on metatherapy related to cognitive communication services. So it's essentially thinking about like what is the patient's role in recovery and how can we talk about that, right? So if we think about like metacognition, it's that thinking about thinking. So metatherapy, it's thinking about therapy. So it's things like how do you help develop self-efficacy? Like what is the patient's role? How can we make sure that that we're like centering the patient's goals and the care and that kind of thing. So we've leaned in on kind of training that and training some of those counseling skills as well. And then just leaning into a little bit more kind of like rehab fundamentals. So using the like RTSS, like what are we doing? What's the goal? And then like kind of what's the target, and then like what are our ingredients? Why do we think that like what is the mechanism by which we think what we're doing in therapy is going to make a change toward that target? So I think we've kind of tried to start formalizing those discussions a little bit more for our trainees and frankly for ourselves, because it keeps us all really centered. Like concussion management should be very functional in nature, right? So like what are the presenting symptoms and how can we help support people with those? How can we help people cope with those, and how can we help reduce those symptoms? So in that way, it's like, it's a little bit black and white, right? Like what's the problem? How can we all work together to solve it? And again, what solving it means is going to differ for each patient. Does that mean coping with it? Does that mean understanding it? Does that mean reducing it? It just depends on the patient and the symptom. But I think that we've like formalized that a little bit more just to get everybody's expectations on the same page. And that's been really important as we've included more people as providers, included more trainees, and kind of expanded our patient population as well.
That's all so helpful. Everything that you all have shared has been incredibly helpful. I wonder, just in our last minute or two, if you have any additional resources, thoughts, suggestions for any SLP listening who is excited by this topic, would like to learn more. Where can our listeners go from here?
I and am not affiliated with them in any way, but resources from ACRM. So American Congress of Rehabilitative Medicine, right? I think I'm getting that right. So they have trainings that you can attend, but also some like treatment guidelines and that kind of thing that have been really helpful for me. It's also like that's their tools are what I use. I teach the graduate like cognitive communication disorders class, and so I use a lot of their tools to kind of help structure the content that we cover in that class as well. So it's really yeah, like kind of really straightforward all in one place. So I would say that's a really that's been a really helpful resource for me personally in my development and in student training as well.
I'll add a resource of the oh gosh, we're gonna do the same thing. BIA, Brain Injury Association of America.
Yep.
Is that yeah?
Yep.
Is a great resource. But I also wanted to just say, like, feel free to reach out to us. You know, part of our mission of our clinic is to um do just this, like educate professionals, educate community, help people get started, kind of learn from our mistakes that we've made. We are willing to share them freely. And so I think reaching out to us at our clinic is a great way to get started as well as a resource.
Awesome.
Yeah. And for me, I remembered the name of the measure that we are using for risk assessment. It's the Columbia Suicide Severity Rating Scale. So people actually have the name of that. And there's, like I said, training widely available for it. And then the other thing that we kind of briefly touched on, but we haven't really gotten a chance to go into detail about, but is come up with almost every single patient who we see is sleep. Being able to assess sleep and to be able to work with clients to help them sleep better, because I mean, there's a number of reasons why we think that sleep can get disrupted because of concussion and brain injury. But we know in terms of recovery that, like, if you're not sleeping, nothing else is going to be going well in terms of like your emotional ability, your cognitive performance, your physical performance. None of it's going to be where it needs to be. And so that's been a big role that psychology has played with this, as kind of being the kind of the central sleep people on the team. But I think any discipline can really do some work to educate themselves on some of the basics of assessing for sleep issues, just asking the question of like, how's your sleep been recently? And if it means a referral, then that's great. If it works, if it's more on sleep hygiene and how do you make some small changes to hopefully help increase their sleep quality and quantity, then that's great too. So that's been a massive thing that we knew was going to be an issue with this population was is their sleep, but I don't think quite even to the scale of what we've seen, where it's really to some degree almost every single patient that we've worked with has had something that we've at least touched on with that. So
I'm glad you said that, because as you know, even though we've all worked together for a long time, we still tend to see things through our own training and our own lens. And I think that something that you just have to be a little bit like humble about is you know, like Jennifer said, like if sleep is not good, then I'm not going to be able to do much to rehab cognition, right? Like if someone is exhausted, I may do, you know, be using best practices related to cognitive stuff, but it's not going to matter. And then I think the other thing, and just thinking about like what to prioritize and what matters most, is one of the strongest evidence-based interventions for concussion is early physical activity. Now, obviously, as a speech path, I'm not going to be the one recommending exactly what people should do and that kind of thing. But if I'm seeing someone as a speech pathologist and I'm not like an integrated part of a team, I am going to say to them, like, hey, I would encourage you to talk to your physician about how exercise might help, right? Like I want to plant that seed at least, because truly that physical activity is it sort of like at all stages of recovery after an initial, and see, Rachel, now I'm getting outside of my wheelhouse, but outside of that first like 24 to 48 hours, pretty much everybody, whether it's 48 hours later or 2 years later, should be engaging in some sort of structured aerobic activity. Now, there are guidelines. Rachel mentioned earlier the Buffalo Concussion Treadmill Test, which is a standardized test to help determine what kind of exercise, what level of exercise you should be doing, and that kind of thing. But really, like sleep and exercise, like those are the things. And so, you know, those are not strictly my wheelhouse for sure, but I need to be like aware of that and able to at least mention to my patients that that is something that they need to consider, because those things play such a critical role in recovery post-concussion.
This has all been really incredibly helpful for anyone listening who is driving, running, folding laundry, what have you. All of the references and resources that these amazing, brilliant minds have shared with us today are listed in the show notes. They will also be listed on our landing page. If you've listened to Earn ASHA CEUs, the link for the post test will also be on our landing page as well as in the show notes. You all have shared so much great information, and we are incredibly grateful for your time. I also want to thank just quickly our team who helps to produce this podcast, which is a labor of love. Quick shout out to Dr. Anna Palamumi, who manages our ASHA CEUs and makes those possible. Our production manager, Tegan Ahern, who keeps our project alive. Darren Lopez, our production assistant, who takes care of all of our marketing materials and web development. Teresa Callahan and Dr. Mary Beth Schmidt, who serve as consultants for our peer review process. And last but not least, our advisory board, who engages with the content review submissions and makes sure that our content is high quality. Them plus you all have shared so much, and we're so grateful for your time. Anyone listening who wants to leave a review or send us an email or find us on social media, we love hearing from you all. We will also list contact information and social media handles and what have you for the rest of our guests today, who have very generously offered their time to connect with anyone who has more questions. Rachel, Jennifer, Laura, thank you so much for being here. This was really great.
It's great to be here. Thank you.
Thanks for having us.
So much.
Thank you so much for joining us in today's episode. As always, you can use this episode for ASHA CEUs. You can also potentially use this episode for other credits depending on the regulations of your governing body. To determine if this episode will count towards professional development in your area of study, please check in with your governing bodies, or you can go to our website, www.slpnerdcast.com. All of the references and information listed throughout the course of the episode will be listed in the show notes. And as always, if you have any questions, please email us at info@slpnerdcast.com. Thank you so much for joining us, and we hope to welcome you back here again soon.